Good evening, everyone, and thank you for joining us tonight for the Renal Genetics presentation, part of Chris O'Brien Lifehouse CPD series. My name is Lydia Connick, and I am a CPD Program Officer here at Central and Eastern Sydney PHN. Also with us is working tonight Sue Moxon, Council's Governance Support and CPD Program Officer. Tonight's session, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I'd also like to extend that respect to Aboriginal colleagues joining us tonight. Please note that this webinar is being recorded and will be available on our website, YouTube library, in the next couple of days. At the end of this presentation, at the end of the webinar, please take your time to submit evaluation survey, which will be available at the chat for you and also will pop up on your screens at the end of the session. Please take your time to fill this out to allow us to issue certificates of attendance and RSCGP points. Please remember also to submit your questions into the Q&A function. Questions will be answered at the end of the presentation, but if you like to ask your question in person, please raise your hand and we'll unmute you. I would like to raise your attention into the upcoming events on the 21st of July, supporting GPs to manage influenza and respiratory infections. 23rd of July, antenatal shared care breastfeeding workshop. 26th of July, assessing and managing peripheral neuropathy. And 28th of July, ophthalmology specialist overview. And all the registrations are available from our website. And now I would like to introduce our facilitator for tonight, Dr. Margaret Woods. Dr. Woods is local GP, member of Education Advisory Committee, and also member of Health Pathways Project. Thank you, Margaret.
Thanks so much, Lydia, and thank you for everyone joining us tonight. I don't know about you, but I just rushed home and got rather wet without the right gear on tonight. So if I look a bit dishevelled, that's why that is. Now, I am here to introduce a very impressive woman whose CV you will hear in a second, but it's seriously impressive. So I would like to introduce Dr. Amali Malawarachi. I knew I would stumble over this. Malawarachi. I hope I have said that right. So Amali is incredibly impressive. She is a clinician scientist whose current research focuses on the understanding the molecular basis of polycystic kidney disease through the application of the latest sequencing technologies. Major areas in this project include investigating novel mutational mechanisms in cyst development and in genetically undiagnosed polycystic kidney disease families. Amali, sorry, I'm going to keep doing this all night, I know. Amali studied medicine at James Cook, so she's from Queensland originally, then completed her physician training in Sydney, went off to the Garvan Institute to do her PhD, and she is Australia's first dual-trained clinical geneticist and nephrologist. I knew you'd be impressed, I am. So as part of her studies, she developed the world first whole genome sequencing-based diagnostic test for autosomal dominant polycystic kidney disease. So I'm really excited to learn what you've got to tell us, Malik, but it's such an interesting area and an area that I guess I'm learning more about all the time. So welcome tonight.
Thank you. Thanks so much for having me, and thanks for the really kind introduction, Margot. Sorry I had to read out that whole bio, but I will just start sharing my screen and we can get started. So I work as a clinical geneticist and nephrologist at Royal Prince Alfred Hospital, and also spend some time in the research lab at the Garvan Institute. I'll just start sharing. So I hope everyone can hear me okay. So the topic I was given today is about kidney genetics. And so just as a little bit of an overview of what I was going to cover today is obviously about kidney genetic conditions, but to spend a bit of time thinking about why we even think about diagnosing kidney genetic conditions and what value there is in that, and to cover some common renal genetic presentations like autosomal dominant polycystic kidney disease and Allport syndrome, and to go through some examples from the clinic to try and cover some of these common presentations, talk a little bit about how to actually access clinical genetic services, and hopefully I'll present this in a way that will be applicable to other disease groups. I am aware that kidney genetics is a pretty niche topic. It's niche even if you're a geneticist. But I hope that the information we'll go through tonight will kind of highlight a little bit some of the common threads for all genetic conditions. I think polycystic kidney disease in particular is a great example of a relatively common genetic condition, and some of the ways that we approach that and some of the things to think about in families with these conditions, thinking particularly about things like family planning and times when genetic diagnosis or genetic counselling can help in people's family planning decisions, and things like reproductive carrier screening, which I suspect that you're all hearing quite a bit about in your practice. I think usually you guys have questions at the end. I'm very happy for you to ask questions in the chat as we go, and for Margot to interrupt if there's anything that's relevant, and also very happy for questions at the end as well. So please feel free to ask away. So I guess to start with, you all know a lot about chronic kidney disease and how common it is. And it really is very common. It affects about 1 in 10 Australians. And genetic kidney disease is not uncommon. And probably we're not diagnosing it as often as we probably it's probably out there. It accounts for about 10% of the adult CKD population, and it accounts for about 50% of the childhood CKD population. When I think about inherited kidney diseases, I try to break it up. I've never been particularly good at memorizing lists, so I try to kind of break it up into the areas of the kidney. I guess first of all are the conditions that give you clear macroscopic differences that we see on imaging. The most common being in terms of cystic kidney diseases and autosomal dominant polycystic kidney disease, and autosomal recessive polycystic kidney disease, which typically presents in children, and ciliopathy conditions like nephronophthisis that also present in children. And then there are the conditions that give us structural anomalies of the renal tract, which are all usually congenital anomalies, and actually are really common. So congenital anomalies of the kidney and urinary tract are one of the most commonly identified anomalies on fetal anomaly scanning. And most of the time they don't result in too much mischief, but sometimes they can. And so they're conditions that we often see quite a lot of in the genetics clinic. And then the rest of the list is certainly not meant to be exhaustive to list every single kidney genetic condition, but basically for all of the different areas of the kidney, there are genetic conditions that affect those areas. In the glomerulus, there's the more common ones are Allport syndrome, genetic causes of nephrotic syndrome, and a number of different genetic causes of focal segmental glomerulosclerosis. And basically all of those conditions present with abnormal functioning of the glomerulus, so proteinuria, and in some cases hematuria. And these patients are usually resistant to a lot of the typical treatments that we use for immune-mediated glomerular disorders. And then there can be disorders that affect the tubules. Lots of different electrolyte-related conditions. Common ones there that I've listed are things like Bartter and Gittleman syndrome, and these conditions often keep pediatric nephrologists very busy as a common presentation in childhood nephrology. And then the interstitium of the kidney can also be affected, and there are dominant tubulointerstitial kidney diseases that often present in adulthood, and then rare complement disorders as well. And I'm certainly not going to go through all of these conditions in detail or really touch on all of many of these today, but that kind of is the overview of different inherited kidney diseases that we often see in the clinic. So I guess one of the most common things that we get asked as geneticists, not just for kidney genetic conditions, but for many different genetic conditions, is whether a genetic diagnosis actually changes anything. I think, first of all, understanding a genetic cause for an inherited condition explains an underlying cause of disease. And I think certainly in our practice, we sometimes, I think, underestimate how much value that has to a patient. Often, a lot of these conditions that are inherited through families are relatively rare and can sometimes be quite difficult to diagnose. And so patients often have been through quite a prolonged diagnostic odyssey to get to the point of a diagnosis. And they really value a reason, a kind of something in black and white as to why they have this condition that has affected their lives so much. A lot of the times for conditions that are diagnosed during pregnancies or in early childhood, it lets people understand why something happened, and also helps people understand that what happened during a pregnancy or was identified during a pregnancy, for example, is not their fault, that it wasn't something they ate or they didn't eat or anything like that, that it was just crazy chance that has resulted in these conditions, and that has a lot of value for families. On top of the value of defining disease, there are often management implications of making genetic diagnoses. Again, this is applicable to more than just kidney disease, but in kidney disease specifically for particular conditions that affect the glomerulus, like genetic nephrotic syndromes, it can avoid unnecessary use of steroids. It can help to target therapy in specific conditions like complement disorders, and it can sometimes predict prognosis. And more, this is becoming the case for lots of genetic conditions. We know that there are increasingly medications that are becoming available that are very much based on your specific genetic diagnosis. And we also know that genetic diagnoses are used more and more to be able to understand which people in a family might need to have more intensive screening, which people in a family are more likely to develop end-stage disease. And so those things can be really valuable. In kidney disease in particular, a genetic diagnosis is really useful when we think about trying to identify kidney donors in families. And in genetic conditions in general, a genetic diagnosis helps us to understand which family members need screening, and also helps us to understand about explaining risk to families when they're extending their family, and in terms of family planning. A lot of renal related conditions are dominantly inherited, and so if you have the condition, you have a 50% risk of passing it on. And so a diagnosis in that situation is really valuable to be able to let people know the specific risk for them when they're having a family. Also, I think there's genetics is getting a lot of prime time at the moment because there's been a huge change in the landscape, which has really been driven by technology and our ability to test people much more readily than we used to in the past. The rebates for this are catching up as well. And in terms of kidney disease, just in the last few weeks, there are now Medicare rebates for genetic testing for patients with suspected kidney disease for nephrologists and clinical geneticists to access. And it means that genetic testing is now much more readily available in these patient groups than they have been in the past. Also, there are increasingly rebates that have recently become available for pre-implantation genetic diagnosis. And I'll go through that in detail in a few more slides, but it essentially means that for families, whether it's kidney disease or other inherited conditions who want to avoid passing on those conditions through IVF and testing of embryos, there are significant rebates that have recently become available for that. That means that that is a technology that is much more accessible now to families than it has been in the past. We also know that there's increasing use of things like reproductive carrier screening for patients with who are in the general population who want to know about their risk of carrying particular genetic conditions prior to planning a pregnancy. And I'll talk a little bit about that in a few slides as well. But there are some common kidney genetic conditions within a lot of those panels. And I think also what has changed a lot in the last 10 years or so is that our understanding of the spectrum of disease is really changing. I think certainly when I went to medical school, the general teaching was that genetic conditions were largely things to worry about in children, and they were often really rare and very severe conditions. And though those conditions still certainly exist, our ability to test more widely has helped us to understand that probably what we were initially describing was the tip of the iceberg, and that there are much broader presentations of all of the genetic conditions that we know of, that have much more subtle presentations, maybe presentations later in life and well into adulthood. And it means that there are far more people that are probably affected with these conditions than we initially understood. And again, that's relevant not just to kidney disease, but across all monogenic disease groups. So before I go any further, I might talk a little bit about genetic testing and a little bit of an overview of genetic testing. So I guess traditionally we learn a lot about the karyotype, about what our chromosomes look like if we look at them under the microscope. And this is a very blurry picture of someone's karyotype here. These days we do a traditional karyotype much less. And we perform a test called a chromosome microarray much more frequently. This type of test is considered a molecular karyotype. And so it still tells us the same information that a karyotype did, which tells us whether someone has the right number of chromosomes. But it can also tell us if there's tiny bits of chromosome material that might be extra or tiny bits that might be missing. And often small pieces of chromosome material that might be extra or missing can be associated with particular genetic and particularly pediatric syndromes. So that's kind of a first pass test that most pediatricians would do when they're seeing children with developmental delay or syndromic features. The chromosome microarray is what happens if patients in a pregnancy have a high risk NIPT result, for example, and they're getting tested to see if they have Down syndrome. So that's still the test that is the test that we use to see extra whole chromosomes, but also allows us to see small pieces of chromosomes that might be missing or extra. If we actually want to look at the code, however, to look at the sequence gene by gene, we do need to sequence the DNA in some way. And traditionally that was done by Sanger sequencing, which is super accurate, but really laborious and time consuming, and really allows you to only sequence one gene or part of a gene at a time. And the game changer in genetics in the last 10, 15 years has been a technology called massively parallel sequencing, which essentially allows us to sequence hundreds or all of our genes at the same time in a very short period. To put it into context, the Human Genome Project was done by Sanger sequencing, and it took about a decade for labs all around the world to sequence one person's genome. These days, because of massively parallel sequencing technology, we can sequence one person's genome in one lab in a few days, or even quicker than that if we need to. So the change in technology in the recent time period has just been remarkable. And so this is most of the testing that happens when people have genetic testing done. A lot of the time they have a test called a gene panel, which means that the test is targeted to a particular set of clinical features, like if they have features of polycystic kidney disease, just genes that can be related to that condition. More and more, a much wider net is cast, and there is testing called whole exome sequencing, which lets us sequence all of the coding regions of the genome. This is often used in very broad phenotypes, like children with developmental delay, or we can sequence everything, which is whole genome sequencing, and this is largely used in the research space at the moment. So I'm going to now switch gears a little bit and talk about some specific conditions. And one of the two conditions that I wanted to touch on is autosomal dominant polycystic kidney disease, or Adpkd. And the reason I wanted to speak about this condition is that it is super common. It's one of the most common monogenic conditions, kidney or not. It affects about 1 in 1,000 people and accounts for about 10% of Australia's renal failure population. The main pathology, as you can see from these pictures, is that kidney cysts overwhelm the normal kidney architecture until and it leads to renal failure. It's a multi-system condition, so it causes hypertension, causes numerous features in the renal tract, including pain from the cysts, renal calculi, urine infections, and hematuria. It can be associated with liver and pancreatic cysts, with cardiac valvular pathology, and in some patients with cerebral aneurysms. In terms of the genetics of Adpkd, it's mostly caused by changes in one of two genes called PKD1, and sorry, there's a typo there, that should say PKD2. There have been some new genes that have been recently identified, but are much smaller players in the game. And it's, as the name says, inherited in a dominant manner, such that if you have the condition, there's a 50% chance of passing it on. And this is just a little picture that I often use to help explain this to patients in the clinic with an affected parent, and that every time they go to have a child, there's a 50% chance of passing on the affected copy of the gene and a 50% chance of passing on the good copy. And I find that drawing things out and visual aids are really helpful when speaking to patients about these types of conditions. We know that PKD1 is much worse and gives you more severe disease than PKD2. In terms of clues for the condition, one of the big clues is nephromegaly. There's not many other conditions that cause you to have enlarged kidneys aside from Adpkd. It's a condition that usually is identified in adulthood, though more and more because children are having more ultrasounds for other reasons, and because our ultrasounds are such good quality, there is more and more PKD being diagnosed in childhood. It's usually in patients who have a family history of the condition, and then they have readily identifiable cysts on ultrasound. Like I said before, there are a number of other clinical features that are clues for the condition as well. And this is some imaging of patients with early PKD when they might have a few cysts, and then as the disease progresses, more and more cysts take over the kidneys until there's no normal kidney tissue left. Diagnosis of PKD is usually based on clinical and ultrasound features. Mostly, it's pretty obvious. Patients have a clear family history of the condition, and they have clearly got cystic disease in their kidneys. So when is genetic counselling and testing helpful when the condition is usually particularly clear? It's useful when clinical features are unclear, perhaps in people who don't have a family history or whose cysts don't look particularly typical. I'll talk a bit more detail that it's particularly helpful in terms of family planning and understanding the risk of someone having an affected child, useful in selecting kidney donors and in screening other family members, and increasing evidence that it's helpful to know what the specific genetic change is, because that allows people to predict prognosis based on the genetic findings. Sorry, I'm pressing too many buttons here. So when would you consider genetic testing? And this is a picture of a family that we see typically in our clinics, where the coloured in people are affected, and you can see that in every generation there is one or multiple affected people in this family. This is a pretty typical inherited kidney disease family, and in this SIB-ship, one sibling donated a kidney to another sibling. The really common questions that we get asked in clinic are, will I pass this on? Can I avoid passing it on? For patients who don't yet have clinical features, they want to know whether they've inherited the condition that their mum or their dad or their brother or sister have. And often those people want to know if they can be a kidney donor for their affected family member. And so in terms of thinking about the reasons why in genetic conditions, whether it's Adpkd or other ones, why we test people that have an obvious clinical diagnosis, a lot of that is around family planning and helping people to understand risk of passing these conditions on. In this particular family, this couple here wanted to know the risk when they have children. And so clarifying the condition in the family helps us to give accurate information in terms of family planning. So identifying that though these people have clinical features of Adpkd, that they definitely have the genetic changes to go along with that, mean that we can say confidently that they have a 50% risk of passing on the condition. And I think that you don't always need to do genetic testing in these situations to give people that information. And genetic counselling is probably the most valuable aspect of the story. And it's amazing, I find, when we see these patients in clinics for counselling, how different families' knowledge is about these conditions. I kind of think that if you're in a family where your father has polycystic kidney disease and your sister has polycystic kidney disease, that you probably have a reasonable understanding of it, but people's understanding varies a lot. I often see family members who say to me, oh, I'm not going to pass the condition on because it's only the redheads in my family that pass this on, or I'm not going to pass this condition on because it's only the firstborn that usually gets affected and I'm the youngest in the family. And so it's really valuable for families to sit down with our genetic counsellors to make sure that they understand the inheritance of their condition and that they have the opportunity to ask those questions and to clarify information. Knowing the specific genetic diagnosis in a family also allows people to avoid passing on particular genetic conditions if that is their preference. And this can be done through pre-implantation genetic diagnosis, in which through IVF, an embryo is made in the laboratory, or several embryos usually. And if the very specific change is known in a family, then an embryo can be biopsied, which is what this picture is here. And some of the cells from that biopsy can be tested for the familial variant. And then an embryo that is unaffected is implanted back into mum's womb. And this can be used for dominant conditions like Adpkd and other non-kidney conditions. It can be used in couples who are both carriers of the same recessive condition, or for women who are carriers of X-linked conditions. But it is all contingent on knowing what the exact specific genetic change is in that family. I mentioned earlier in my presentation that there's been some new Medicare rebates that have become available in the last several months that now heavily subsidise this testing. It doesn't cover it entirely, is my understanding, but I think that differs between lab to lab. But this used to be pretty inaccessible for most patients, but the recent rebates mean that it is much more accessible to families now, and there's new clinics in Sydney that are offering this type of genetic diagnosis for families with known conditions. So I think it's something that we're trying to discuss with families so that they know that this is an option for them. It's not for everybody, but a lot of people don't even know that this type of technology or testing exists, or that it's something that is now accessible and not kind of financially prohibitive. This is just some research that our lab did a few years ago looking at genetic testing in PKD patients, and some of the value of testing in patients without typical clinical features. So we looked at a cohort of patients who'd undergone genetic testing for Adpkd, and we split that group into people who had typical textbook features of the condition and people who didn't quite fit the textbook, who had atypical clinical features. And what was surprising was that about 60% of people with atypical features still had a genetic diagnosis made. But when you have a look at this second graph here, the patients with typical clinical features of Adpkd had changes in the most common genes associated with the condition, whereas people with atypical clinical features had changes in a number of different genes that we think are not so commonly associated with the condition and are importantly not distinguishable based on clinical features, and even more importantly, have different prognosis diagnosis to the traditional PKD gene. So they're less likely in a lot of instances to cause kidney failure. And so this is really useful information when you're seeing someone, so that you can kind of give them definitive prognostic information, and is another reason that we think about genetic testing. I'm now going to switch to a different condition, Allport syndrome, which is less common than polycystic kidney disease, but still is a condition that we see quite a bit. It is an abnormality of type 4 collagen, and collagen is really important for lots of basement membranes in cells. This particular subclass of collagen is important in the glomerular basement membrane of the kidney, and also in the cochlea and the eyes. And that kind of makes sense to me because Allport syndrome affects your kidneys, it affects hearing, and you can get changes in the eyes as well. There are really specific changes on kidney biopsy that are pathognomic of Allport syndrome. There are 3 genes involved in Allport syndrome. 2 are on chromosome 2 on an autosome, Col4A3 and 4, and then 1 is X-linked, Col4A5. Classically, the conditions on the autosome were thought of as a recessive disease. And the classic textbook version of Allport syndrome is of small children that present with hematuria, who usually develop deafness in primary school and renal failure in childhood. And the X-linked version is by far more common than the autosomal versions. But as I said at the beginning of the talk, our understanding of disease spectrum is really changing. And actually, the more testing that we do, we're understanding that there is a pretty huge spectrum for Allport syndrome that ranges from patients having non-progressive hematuria and never anything else, to patients who have end-stage kidney disease. And sometimes that can be due to relatively similar genetic variants. Increasingly, it's being identified that patients with steroid-resistant nephrotic syndrome can have changes in these Allport syndrome-related genes without those textbook biopsy changes that we were taught should always be seen in Allport syndrome, and again highlights that the spectrum of disease is changing. There's also increasing evidence that having just one change in one of the previously understood to be recessive Allport syndrome genes can give you a risk of kidney disease. And so because of that, that change in the understanding of disease spectrum, there's a bit of an impetus in the field to avoid some of the descriptive words that we used to use, or nephrologists used to like to use, like benign familial hematuria, because it may be that hematuria in some of these families with Allport syndrome changes is not benign. And to try and get people to understand that even having one change in some of these genes can mean that you have some risk of developing kidney disease, though that can be pretty difficult to tease out what that risk is. And most guidelines recommend that patients are screened with blood pressure and urinalysis if they have single changes in one of these genes. So when does this become relevant for the general population, for people who don't turn up to nephrology clinics with blood hypertension or with CKD? And I think reproductive carrier screening is one time to think about that. This is a patient that I saw in clinic who is a 34-year-old man who he and his wife underwent reproductive carrier screening as part of their pre-pregnancy planning. And this gentleman was identified to have a change in one of those autosomal Allport syndrome genes in Col4A3 that sits on chromosome 2. So he had one copy of the gene with the problem and the other copy was completely fine. And what is highlighted in this report is that some individuals with single changes in Col4A3, as he has, can have symptoms. And that was some of the literature that I was discussing in the previous slide, that there are some patients with just one change in this gene that can have risk of developing chronic kidney disease. And so this is something that was highlighted to him and was sent along to have screening in that context. So just as a little bit of a recap, about reproductive carrier screening, which I probably don't need to give this audience a recap on, but it is an optional screening test that can happen ideally pre-pregnancy in couples who are planning pregnancies, and it screens couples for being genetic carriers for some X-linked and recessive conditions. And as you're probably aware, there are many different commercial options for reproductive carrier screening, and the number of conditions that are screened for varies between the tests and the providers that offer this testing, and it can range from just screening 3 or 4 common or more common conditions such as Fragile X syndrome or cystic fibrosis to screening 300 or 400 different recessive and X-linked conditions. At the moment, there are out-of-pocket costs for patients to access this type of testing. And usually when we counsel patients for this type of testing, we say that there are generally no health implications to the couple of having this testing, that the aim of this testing is to understand if the couple together are at risk of having a child that could be affected with a genetic condition. But there are always caveats to everything that we do in medicine. And there are some conditions for which identifying that a couple or one person in a couple is a carrier can have health implications. And so Allport syndrome, going back to this report, is one of those examples. And there are a number of X-linked conditions for women that are examples too. I don't think that point needs to be over highlighted. For the vast majority of people, there is no implication at all for themselves with carrier screening, but it's something that we very briefly mention when people are having carrier screening consenting done. And so when we asked more history in this gentleman, his father had chronic kidney disease and he also had the same variant. And so this family was counselled that this is likely a risk factor in them developing chronic kidney disease. It's difficult to quantify what degree of risk it's attributing to the kidney disease in the family, but this gentleman will now be surveilled through his lifetime to make sure that he's not developing CKD or to catch it early if he is. So I'm just going to go through a few clinical cases just to illustrate a few more points. This is another family that I've seen in the clinic, and I actually met this young lady here whose brother had a diagnosis of autosomal recessive polycystic kidney disease. And she came along because she and her husband were wanting to start thinking about planning a family. And she wanted to know what her risk was of having a child with the same condition as her brother. This is a recessive condition, and in general, whether it's autosomal recessive polycystic kidney disease or other recessive conditions like cystic fibrosis, for example, we like to start answering this question for families by starting with the affected family member. Because first of all, we want to confirm the genetic diagnosis in the family. Sometimes genetic diagnoses are really obvious with clinical features alone, but sometimes there can be overlap. And before we can give people information on the risk of recurrence in another generation, we need to know what the specific genetic diagnosis is. And so so the first thing that we would do is to assess or clarify what the specific genetic diagnosis is. And then after that, we can offer carrier screening to the siblings of an affected person. And then that information often, in terms of whether further testing is done in a family, there's a few different factors that come into play there. There are some genetic conditions for which it is exceedingly rare that an unrelated person in the population, so that for this person's husband to be a carrier for a condition, and we can give stats on that, and people may elect in that situation to not have any more genetic testing. Or there are conditions like cystic fibrosis, we know, where the chances of an unrelated individual being a carrier for a familial condition is really high, or relatively high, and so that they could elect for carrier screening. And so that's kind of the thinking that we think about when we get referred patients like this in the clinic. And so I wanted to finish up by talking about a very rare case. So I guess all the examples that I've discussed so far have been relatively more common for genetic conditions. But I'm going to finish up talking about one that is exceedingly rare, but I think will hopefully highlight some of the advances in genetic testing that are available currently. So this is a lady that I met during her pregnancy. She had a naturally conceived pregnancy with low risk first trimester screening, and she'd had a normal ultrasound, in her morphology ultrasound at 20 weeks and then a normal ultrasound at 28 weeks. But she presented at 31 weeks with reduced fetal movements. And at that time, it was found that there was no amniotic fluid present. The fetus otherwise looked normal, and in particular, there was normal renal morphology. She, in the context of this finding, underwent fetal whole exome sequencing. So a fetal sample was obtained, and exome sequencing was performed on that sample because there was high suspicion for a genetic reason for the anhydramnios. She had already had excluded an amniotic fluid leak, which is by far the much more common reason for this presentation. But the obstetricians pretty strongly felt that that is not what was going on. And so a genetic cause for the anhydramnios was investigated for. And through this testing, there were a genetic diagnosis was made. The fetus was diagnosed with a recessive condition called renal tubular dysgenesis. And this is an extremely severe condition that's characterized by fetal anuria. After a particular gestation, the kidneys stop making urine, and there is oligohydramnios or anhydramnios. It's usually in the setting of normal looking kidneys on fetal ultrasound, and it results after delivery in profound, often treatment refractory hypotension, and it's usually a non-survivable condition. It is extremely rare, and it's primarily a defect of the renin-angiotensin system. And we all know renin-angiotensin well because we often block that system through use of antihypertensives. But this particular condition causes a defect in some of the proteins in that renin-angiotensin system, and causes the kidneys to then not be able to develop past a particular part of development. It's actually the same clinical features that are seen in a fetus if there's been maternal ACE inhibitor or ARB use in a pregnancy. It's inherited in an autosomal recessive manner, so that both of these parents were identified to be healthy carriers unknowingly for this condition. In the context of this finding, during the pregnancy, the couple made a decision for comfort care after delivery, and their daughter passed away a few days after delivery. This diagnosis was all made prenatally, and more we're seeing for very rare presentations like this, prenatal genomic testing used, where very broad genetic testing is performed in a pregnancy, much more than looking to see that there's the right number of chromosomes, but looking at many or all of the genes. And in this situation, the analysis was targeted to the clinical features seen in the pregnancy, and it's done pretty quickly in the world of genetic testing. I think this result was available in about 2 weeks, and so can allow couples to make decisions. So what is the value of this type of testing? For this family, it clarified the diagnosis during the pregnancy at a time when it was very uncertain what the cause of the lack of amniotic fluid was, and it allowed the opportunity for them to receive counselling during the pregnancy about prognosis and to discuss possible outcomes after delivery so that they could plan for the mode of delivery and how much intervention they wanted post-delivery. It also, for couples that for whom that is something they would consider, allows them to consider stopping a pregnancy. And so it assists in preparing the family and in preparing clinicians in these rare situations of very severe fetal anomalies. So I will wrap up with just a few general points. The first is who to consider for a genetic diagnosis. And I think there's lots of different groups of people to consider. First of all, it's the obvious. It's the people who have a clear diagnosis of Adpkd or cystic fibrosis, who may not have previously had genetic testing or may not have previously had genetic counselling, or a lot of the time people who had childhood diagnoses of conditions who have not had genetic counselling in adulthood. And those are people that I think really get benefit from meeting a genetic counsellor and going through the genetics of their condition so that they can understand the inheritance pattern and their diagnosis. I often think that genetic diagnosis is worth thinking about in young people who present with severe disease, because we know that for many conditions, the younger you are, the more likely you are to have a monogenic cause for severe disease. I think it's worth thinking about in patients who have atypical or multi-system features to think, is there an underlying single cause that helps to link together all of these multi-system features? And I thought I would just cover some common questions that we often get asked in relation to genetic testing. Very commonly, we get asked mostly by doctors and far less by patients about the insurance implications of genetic testing. Genetic testing can have implications for some types of insurance, definitely not for things like health insurance or private health insurance, but potentially implications for things like income protection or life insurance. There has been recent or relatively recent changes to laws in Australia that means that companies cannot completely exclude people from insurance because of a genetic diagnosis, but they can choose to insure someone for less than like a lower value. I think one thing to remember about this is that I think it's something that often gets asked by clinicians, but patients, in my experience, are far less concerned about this. If they've got a condition in a family and they want to use the genetic information to help inform family planning or risk, then that to them is a really valuable reason to have testing. The other thing is that in reality, the vast majority of people that we test have clinical features of a condition, and that usually trumps them being able to get insurance above any genetic result that we give them. The times that insurance implications are important to consider is predictive testing, when we might be testing a family member who doesn't yet have features of a condition. And then this is something that we do go through as part of our genetic counselling process before testing is completed. Another common question is about, isn't genetic testing really expensive and not accessible? And I think, as I've tried to highlight through this talk, that is changing, and it is much more accessible than it was even a few years ago. And I hope I have highlighted that it does change things. It may not mean that making a diagnosis means we can cure conditions yet, but it does give people a diagnosis and it helps people to understand risk and prognosis. Some really useful resources that I use all of the time. You may know about the Centre for Genetics Education, which is run by New South Wales Health. It's a fantastic website, and the website link is there, full of fact sheets for genetic conditions. I use these fact sheets a lot to talk to family members and to give me sometimes a little refresher on the best way to explain a genetic condition to families. Often there are many common genetic conditions listed there, many common modes, all the common modes of inheritance. There are also great fact sheets about NIPT testing, about reproductive carrier testing and common genetic tests. And so that's a really great place to get resources from. Another a great resource for getting kind of an overview about genetic conditions is called Gene Reviews. And essentially it gives you a summary for most genetic conditions. There's a great summary at the top and then lots more detail if there are more specific details that you are after. But again, if I'm seeing a patient with a particular condition, it's often a really great refresher to go to Gene Reviews and read about the most up-to-date information about those conditions. So I'd highly recommend those two resources. And how do you refer patients to genetic services? Through that Centre for Genetics Education website, there are lists of local genetic services, and the services are split based on local health districts. And so depending on where your patient lives, you can access the specific clinical genetic service for your area. In terms of kidney genetics, we have some specific kidney genetics clinics in Sydney at both of the children's hospitals, at Westmead Adult Hospitals and at Sydney Local Health District, which is the clinics that I run at RPA and at Concord Hospital. And so there are details for all of these different services through the Centre for Genetics Education. So I'm going to finish up with my last slide and just highlight that genetics can offer an additional layer of information for patients to help with understanding pathogenesis and to give them a specific diagnosis, which can be really valuable for families. I hope I've highlighted some of the management and familial implications of genetic testing and the times when it's useful to consider it in the management of your patient. The last thing to highlight is that there is much more to clinical genetics than just genetic testing, and a large part of it is about genetic counselling and helping people to understand about their disease. And so for patients who may not be interested in a test, there is still often value in genetic counselling and understanding about their disease without necessarily needing to have a genetic test. And we're very happy in clinical genetics to be contacted for advice. And so please do that. And I've put my email address there if anyone has any questions that they'd like to get in touch with me about. So with that, I will stop talking and see if there are any questions.
Thank you so much, Emily. That's such an interesting area, isn't it? And I would certainly concur that the Centre for Genetics Education has some fantastic resources and some really good online courses to do. So it's a great place to start.
Yeah.
So everybody, that you can ask questions in the Q&A, or if you want, just pop your hand up and we can unmute you. But let's just do the couple of questions that came in while you were speaking, Emily, first. The first one, I think part of it is around who do we send? So what are the indications for genetic testing? Well, actually, I should say for referral to genetic services rather than necessarily genetic testing, as you just pointed out. Should patients with persistent microscopic hematuria undergo genetic testing, assuming that, that we've excluded other causes of hematuria in those patients?
Yeah, excellent question. And I wish there was one excellent answer for this question. It's really hard. So I was actually looking up because Margot gave me access to health pathways, about the health pathways for hematuria. And I think the first thing is to kind of go through those pathways. It's a thing that is discussed a lot in nephrology at the moment about which patients with persistent microscopic hematuria should be considered for an Allport syndrome diagnosis. There are some studies that say that about 1% of the population are carriers for Allport syndrome, and so it's not really feasible to be testing all those people, nor is it probably necessary, because most of those people are probably wondering about without ever developing any kidney disease. And so what we kind of advise at the moment is that families, for people who have proteinuria in addition to their hematuria, should certainly be considered, or if they have other features of chronic kidney disease like hypertension or reduction in their GFR, should be considered for genetic testing. Also, and I guess that's if other immune and other causes have been considered already. Patients who have a family history of kidney disease, so people who have other family members with CKD, which may or may not be explained, and then also have persistent hematuria, are important to consider. And I think particularly considering it in women of childbearing age, if they have family histories, just because of the potential for X-linked Allport syndrome, where women can sometimes have hematuria and not any other features of Allport syndrome, and then have much more affected sons. And so those are the kind of situations where I think about genetic testing for hematuria. But unfortunately, there's no kind of black and white guidelines. And I think it's really because it's probably much more common than we realize, and most people are wondering about without the same risk that is in the literature, which probably reflects some significant ascertainment bias.
Must admit, it makes me think I've probably got a lot of patients that I should be
thinking
about.
As soon as I do these talks, everybody thinks that. I think often, like, our usual clinical red flags are the same ones, the patients with other features of kidney disease and proteinuria.
Yeah. Fantastic. The next question really is an interesting one about if family where there is PKD. So they're asking, at what age should a child have an ultrasound to confirm that, or is that the best approach? Do you use ultrasound to screen children with family members?
Yeah, so this is also a great question. In terms of, for families who have a clear family history of Adpkd, the guidelines and, well, the literature would tell us that if someone has a parent with Adpkd and they go and get an ultrasound, if they're a young person, even having 1 or 2 cysts in their kidneys gives them a diagnosis of Adpkd. Obviously that changes as people get older, but if we're talking about children or young adults, 1 or 2 cysts is actually enough to clinch a diagnosis if your parent has the condition. And so ultrasound has traditionally been the first go-to tool for diagnosing Adpkd. But I think one of the main things to think about is that if you're taking a healthy person who doesn't have any medical conditions, and then we go and do an ultrasound, or essentially doing a predictive test on them, because that ultrasound result will then give them a diagnosis of Adpkd. And for someone who has a family history of the condition in their parents and who knew they were at 50-50 risk, that may not be a big deal. But for some people, it may be a deal, and it may be quite a surprise to them that you know, they have an ultrasound done, and often a sonographer says to them, oh, well, you've got PKD like your mum. And that's a big deal for someone who may have watched their parent go through dialysis or transplant and have significant morbidity. And so I always think that it's really important that patients are aware that that is the potential implication of the test that they're doing, and that they just have an understanding of that before the ultrasound is done. And then as a first go-to test, if the patient is on board with that, an ultrasound is very good. A negative ultrasound is not as informative. So in a person before the age of 40, a negative ultrasound doesn't rule out the disease. And so if you're kind of in your childbearing years, you have a parent with Adpkd and your ultrasound has not identified cysts, mostly you probably are off the hook, but not 100%. And that's where genetic testing can be really valuable, that you can give people a much more black and white answer if they have a genetic test in the setting of an ultrasound being normal or equivocal. I hope that answers the question.
Yeah, no, that's really good. So because you're building on the information for them, aren't you? So,
yeah, that's right. And I think generally for those predictive type tests, we tend to not ultrasound screen or genetic test screen children during childhood unless there's a medical indication, because at the moment there isn't really a huge, we don't have a treatment we can give kids if we diagnose them with Adpkd. So we feel like letting them become adults and choosing for themselves whether they want that diagnosis or not is the traditional thinking. We would still recommend that children who have a parent with Adpkd get blood pressure screening though. So when they're in the clinic for another reason, or at least once a year, they're having their blood pressure screened. Yep. But we tend to not test them just because of the family history in childhood, though that teaching probably is going to change, but that's our current understanding.
Fantastic. So the next question is about deafness. So if a husband has hearing loss in his parents and he wants to check for a genetic component before having a family, do you check the husband for this specific condition or all the genomic testing? Is this to go to a genetic counsellor, and any reason his wife should be checked as well?
So generally, if someone comes and they're asking about the risk of a very specific condition in their family, and in this example, hearing loss, we tend to like to first test the person in the family who has the condition. So that way it allows us to do hearing loss genetic testing and say, this is the diagnosis for hearing loss in the parent, and then we can know what the risk is for the subsequent generations. It's done for a few reasons. The first thing is if we, for example, just tested the husband rather than his affected parent, a normal result is not totally informative, in that it may be normal because they didn't inherit the change from their parent, but it may be normal because we ordered the wrong test, and that's difficult to discern. And that's why we like to test the affected person in the family as the first person. Sometimes that's not possible and it becomes really difficult, and that then becomes a bit of a case-by-case situation on what the condition is, whether there are other clinical features we can look for, and how common or rare it is as well. So that's the kind of thinking about if there's a known condition in a family. If there isn't a known condition and someone kind of comes to you saying, I'm worried about deafness and other genetic conditions, but I have no family history, then reproductive carrier screening is something to talk to those couples about. And there are many options for reproductive carrier screening, as I'm sure you all know, and they cover different conditions. And the things that I highlight to people is that no screening test reduces risk for everything, that it's a risk reduction strategy that will look for some conditions, but certainly not everything. And so that's kind of my approach for those situations.
Lovely. Patients with liver cysts on abdominal ultrasounds, which is, as we all know, quite a common incidental finding, is that a marker for any genetic disorder?
Yeah, it's tricky because liver and kidney cysts are both really common, particularly as people get older. I would say that it depends if I guess the number of cysts. Obviously, if the liver is really overwhelmed with cysts, then I think that's important to look into. And if there's other associated features or associated liver dysfunction, then it's useful to look into. The conditions that come to mind for liver cysts is there's autosomal dominant polycystic liver disease, which tends to actually be a relatively more benign condition compared to the kidney version, in that it doesn't cause liver failure, but it can often cause local effect of having lots of cysts in the kidneys. A common reason for cysts in the liver is also polycystic kidney disease. So if there are a number of cysts in the liver and family history of kidney disease in people, it might be worth checking that their kidneys don't also have cysts. But otherwise, if there isn't overwhelming lots of cysts, I wouldn't kind of jump to thinking about genetic testing in that situation.
Fabulous. There's more questions. If anyone wants to ask any more questions, please pop it in the question area. But I just had a quick, just thinking about our role as GPs and what, we've thought about what some of the indications for sending for genetic counselling, but what can we do? I mean, should we do one of the family trees? Should we do any preparatory counselling, use some of those resources, or is it something that we should really just refer directly on?
Yeah, I mean, I think you're the people that know the families really well, and so information about family trees is often really helpful in terms of, you may know other family members or have known this person for a long time, and so know their history, and that information is really valuable. I think also that in terms of explaining genetic risk for particularly some of the more common conditions where people have a clear diagnosis, like cystic fibrosis or polycystic kidney disease as examples, I find using the resources just for the diagrams and going through risk and making people getting an understanding of what they know and explaining things is really helpful. And though they may go through that with the genetic counsellor, again, I think layers of hearing the same thing again is often very helpful. Or you may have families who you do go through that initial piece of information with, and they say, look, I actually know this, and that's kind of the information I needed. And if you feel comfortable with that, that's also great. Like I said, not everybody actually wants a test. A lot of people just want to understand what the risk is, and everyone's feeling about risk is different. And for some families, you say the risk is 50% and they go, oh, that's great, I thought it was 100%. Whereas I think that's very high risk.
Exactly.
So I think going through it with families is really helpful, for everyone. And people often like to hear that information from people they trust rather than strangers as well. So
does everyone see a genetic counsellor when they come into the genetic clinic?
Mostly. For the most part, the way our services work is that when referrals come in, patients are often contacted by a genetic counsellor who spends some time with them over the phone, going through their family history and kind of a big picture of their clinical information. And then in some situations, they'll get triaged to say that this person has a clear diagnosis, and they should meet a genetic counsellor in a clinic to go through some of the counselling implications of their diagnosis. Or if patients have more of a diagnostic dilemma, then they may get triaged to see a clinical geneticist. And in that situation, a lot of the times we see patients with a genetic counsellor and sometimes not, depending on the situation. And often it happens over a number of clinics. So sometimes we might meet someone for the first time and then with results meet someone with the genetic counsellor. So it's a little bit varied. And sometimes we meet people at different stages. So we might make a diagnosis in someone and then 10 years later see them when they're planning their family, and then meet their children down the line. And we try to keep all of that information available, and genetic services in New South Wales are actually all linked so that we can hopefully see if someone's been seen in another service and not double up on testing.
That makes me wonder a lot about confidentiality and how that all works, but we'll just skip ahead and ask the question that's on the screen. But that sounds like a tiger's den of issues around confidentiality. We do get consent
for all of those things.
Exactly. Okay, so women are often delaying the age of conception and often are already anxious about conceiving. How should we have a dialogue about genetic counselling without increasing their anxiety?
Yeah, I think it's a great question and often really hard to do. For things like reproductive carrier screening, I try to frame it as a screening test that is an option for families. And so I kind of frame it as if that, you know, there is this type of testing that's now available that allows us to screen if particular people as a couple are at increased risk of some inherited conditions. And I try to reiterate that most of the conditions that we screen for are really rare, but collectively there is some value in testing for it, and that it is about how people approach risk and pregnancy, and I kind of use an analogy that, you know, I sometimes meet couples who kind of feel like before they have a pregnancy they like to leave no stone unturned and know do all the tests that they can do, and if that's the case then this is an option of a test you can do. I also meet lots of couples that say that, look, all pregnancy is a risk no matter how many tests I do, and in that case this is a test I don't want to do, and both of those options are fine. And then I kind of try to let people choose about what they feel comfortable with. Sometimes some people are information seekers and so love the idea of doing more tests, and other people do prefer to let sleeping dogs lie. So that's kind of how I frame it. And I try to not frame it in that people have to do this type of testing, nor that they're at high risk, because neither of those things are the case. It's an optional extra. And I often say, like, these were not options that were available to our parents' generations, and there's pros and cons to that. But this is another option, just like, you know, detailed ultrasounds and other things that you can do in a pregnancy if it gives you some relief in doing that.
Just clarify, as a GP in nephrology, I wouldn't be ordering any genetic tests myself. I would be referring people that I think who might need testing to your service.
Yeah, absolutely.
Yeah.
Yep. So in terms of genetic testing, most genetic testing is still ordered just through clinical genetics units, and that has a lot to do with the funding of testing. The Medicare rebates for testing have literally just come out in the last month, and some of them do allow for nephrologists or other specialists to order tests in particular situations. And so largely the testing is done through clinical genetic services, and that's around funding and genetic counselling and consent processes as well. I guess the types of genetic testing and that might be ordered in general practice, I guess, will be things like reproductive carrier screening, so the screening tests rather than the ones for making a specific diagnosis.
Fantastic. Any more questions at all? Because there have been some really good questions. Thank you for that. That's really, they've highlighted quite a few things. And if you want to pop your hand up, you certainly can ask a question yourself. We might actually just have a really quick look at health pathways too. So we have Well, I guess as all areas, health pathways, information on genetics is growing. We're getting more and more information on genetic testing. And I just thought we'd have a quick look. We actually don't have a specific pathway on nephrology testing. So now you've inspired us to think maybe we should do that. But I thought it might be worth having a look at what we actually do have around the genetic testing.
Yeah.
And so everybody in the webinar should have access to health pathways, and I'm sure you're all aware of what that is. So there's the Sydney health pathways and there's Southeast Sydney health pathways, and the username for both of them is connected, and the password is healthcare. Southeast Sydney have another one as well, but that password will work for both of those, so Sydney and Southeast Sydney. So Sue or Liddy, can I maybe just have a share screen and just have a quick look at what we've got?
Yeah, you can share screen right now.
Fantastic. Okay, brilliant. Okay, so I'm sure you're all very familiar with, this is Southeast, no, hang on, sorry, I'm looking at the wrong screen. This is Sydney Community Health Pathways, and this is Southeast Sydney Health Pathways. So I'm sure you're familiar with those. So if I go back to the Sydney, just because I'm more familiar with that, there's a number of ways of finding our genetic pathways. So you can certainly use the search menu up the top here and the search bar there, or some other ways to be looking. For me, I know it's sitting in medical, and then I've got genetics. So I've just dropped those, opened that menu up there. So you could search with that, as I said, through the search bar or through here. Now you'll notice that some of those under genetics are grey, and some of them are black. So for those who aren't all that familiar with health pathways, I'll just click on a grey one and it comes up with a yellow background. Now that's actually not adapted for us. We haven't actually changed that from what New Zealand has done. So you'll see in there that actually still refers to New Zealand. So any pathway that is yellow will not give you access to the local services, because it's still speaking about New Zealand. Doesn't mean it's got wrong clinical information, but it just won't be localised and the services aren't localised. So if we go back again and we have a look at the common genetic conditions, these are the ones we actually have pathways on. So the dark ones here. So cystic fibrosis. Oops, there's lots of big images on the front there. Not sure why that is. So we have cystic fibrosis genetics. We have congenital heart disease genetics, Down syndrome, children with dysmorphic features, Huntington's disease, Marfan syndrome, myotonic dystrophy. So they're the ones specifically about those conditions. Then we have a whole suite on familial cancer syndromes. So when it might be appropriate to refer someone to genetic counselling or testing in familial cancer syndromes. Plus, of course, you'll know we've got our pregnancy screening about the prenatal and antenatal ones as well. I'll just quickly go into this one, the genetic testing. This is, I guess, where you'll find this information about how to find Amali, because in here we have the genetic health assessment. And so it lists the public services, the cancer-specific genetics, the cardiac genetics, and perinatal genetics, as well as the cancer-specific, so private genetic services. So, Amali, where do you sit? Do we refer to you in the general genetics?
General genetics, yes.
Right. So if it doesn't fit one of the other specialties, then the specialist clinics, then we would send to you. So I'm sure everyone's familiar with the format, so that would give you the information that is required to send someone to the clinic. Plus, it will give you how to actually do that. So we now contact the provider. So it actually, I can't even see exactly how to do that there. So but it should, there it is there. And the next one I click down, there it is there. Yeah,
and then
it is there.
A referral form that has all our
details. Fantastic. So should have all of the information you need, how to access that clinic, plus the name of some of the geneticists at the clinic. And there you are, found you. So you're in there. So that's good. Yeah. So any questions about health pathways or suggestions for health pathways? Because as you know, health pathways is very dynamic. And if you think there's any specific things we should add, please pop it in the chat now or ask any questions about that. Got a chat, fantastic. Although that was from Lydia, so that wasn't a question. That's from Lydia. Thank you for joining us all tonight. Okay, so I might stop sharing my screen, but I would recommend having a look around there, and you will certainly hopefully find, particularly, I guess, the referrals where you would send a patient to get assessed is really important. So that's all on there correctly, and we can find you, which is great. So any other questions at all? Otherwise, I think we look like we might be getting an early mark tonight.
Well
It's not a bad thing. Yeah, that's right. Not a bad thing. And I really, really appreciate it's been so interesting, and it's certainly an area where our knowledge is just growing and growing. So we might have to have you back next year and the year after, because I'm sure there'll be more things for us to learn then as well. So thank you so much, and good night.
Pleasure. Thanks very much.
Pleasure.
Thank you very much once again, Dr. Margot Woods and Dr. Amali Malawarachi. Thank you for your contribution. Very interesting session and very comprehensive. Thank you everyone for attending despite the weather, the cold, and everything above. Please take your time, fill out a evaluation form so we can get your feedback, which is very, very important to us. We're looking forward to seeing you next month for the Chris O'Brien Lifehouse update, and we'll be talking on dermatology.